Welcome to the ambulance transports during inpatient hospital stays. A lot of people may refer to this as an H2H, origin destination H2H transport. I'm Tom Ryan with Provider Outreach and Education, and I'll be your presenter today. I'm by Leanne Foster from my team, and she's going to help with the chat, the technical, anything that comes up like that. So again, put those questions in chat if you have them. We do want to hear from you. I do want to make you aware a little bit about this webinar, a little background on it. This webinar is in response to your questions. So we've held a lot of other ambulance education. We've read the surveys, we've listened to you, and we've looked at what you're asking us. And to do that, one of the things we discovered is that you were asking about hospital to hospital transports during an inpatient stay. So the key thing here is inpatient, and we'll explain all of that just in a little while here. But I wanted to let you know that this information is all built based on the questions that you answer, trying to get through all of those different questions that you had answered. So throughout, I'll bring up points of view that do come up. With that said, let's go ahead and head over to our disclaimer here. So we did prepare this information. I have verified that it is as current as it can be. But as everyone's aware who's been working with Medicare for more than 5 minutes, Medicare does change. This means that the Center for Medicare and Medicaid Services, CMS, website has the most current information and all of the rules and regulations. We as a contractor do house guidance on our website. However, we do not have the rules and regulations. If our guidance is different than what CMS has on their website, then you must follow the CMS website. Again, I will answer questions and try to give you facts based on those questions throughout this presentation. One thing to remember is that if you add in additional information, take things out, change the way things sound, this can really affect my answer. So if you have questions based on something that I'm giving you, please put those back in the chat. We'll get some clarification for you. Also, CMS does prohibit the recording of this presentation for profit-making purposes. We ask that you don't record, do screen prints, or any other type of material like that, because we can't guarantee how you're going to use it. Instead, what we're going to do is we're going to give you the opportunity to listen to an encore. And that encore is going to be available on our YouTube channel. So what I want to do is just take a moment, because I actually am going to answer the first question: where's this encore going to be at, before we even get into our agenda? So a couple people are having trouble finding some of the different encores. So if you go to youtube.com and you search WPSGHA, you'll come to this page. This is our landing page. Go to this videos playlist. So videos, then you're gonna go to playlist. Videos will make you look through everything. I like the playlist. I think they're easier to use myself, just how I like to do it. When I open up the playlist, there's a couple of different ways you can find this. One, if I scroll down, there's one called Encores and there's one called Ambulance. Now again, you can scroll down to these if you want to. I don't typically do that. You can see here's Encore presentations. How I find is to use this magnifying glass, and I type the word, if I know how to type, Encore. When I hit search or the magnifying glass, it just brings me up, and then you can see the full playlist is available. Now, I will tell you our Encore playlist is pretty big and it grows every day. What we do is put content out here on this playlist, and it gets bigger and bigger and bigger, because as we load more content, we don't take stuff down unless it's irrelevant, doesn't have factuals. The other way to do that is, I don't want to look at all this general Encore stuff. I only want to look at ambulance information. Come to the ambulance supplier playlist. Okay. When you do that, you'll see a whole list of videos right here on the side, and you can scroll through and just check those out at your will. So it just brings up a lot of information for you. We have had some people that have asked us for certain information that we already have available out here. So if you're saying I want ambulance education, but you're not being more specific, you're not really helping yourself, because I don't know what you need beyond what's already out here. All right, back to this. Question number one done. Where are you going to find the Encore? On the playlist. Okay, let's move on. What does this live education today cover? Our goal is to talk about the Medicare ambulance benefit. In particular, we're going to determine who to bill when the patient is inpatient in a hospital, not necessarily skilled nursing facility. That's already been done. There's a whole Encore presentation. It's an hour long about just that process. This is inpatient hospital. That's why it was advertised in the manner that it was. Then we're going to talk about some actions to take when Medicare recoups our payments and what you need to be aware of and how you need to do that. So what is our objective, or what is our goal? We really want you to be able to bill ambulance claims correctly the first time. Save yourself the time, save yourself the money, save us the time and money to not have to bounce back and forth. So with that said, I did take questions in advance and I will go through those. I will mention various questions as I come to various sections of the class too. So just know that there's going to be mixed in for some of those pre-submitted things. All right. First item to cover, we're going to define the ambulance benefit because Medicare ambulance benefit is very specific and there's some very key definitions you have to know even when the patient is inpatient. So let's start with the definition of an ambulance benefit. The first thing is that it has to be medically necessary. A lot of people ask us this and what that means. It means that in order for Medicare to even consider the charges, whether it's part of a hospital bill or not, which means the patient is inpatient, those charges have to be medically necessary. Why is the patient going today? What skills of the EMT are needed? Or why do they need to be monitored in the manner that they do to get whatever the end result is? Why is it medically necessary today? Many people ask us about where this comes from, and it's actually written into the Social Security Act. So unlike a lot of things that say medically necessary is just 1862 A1A, again, that was 1862 A1A, and it simply says, we don't pay for things that aren't medically necessary. There's a specific section, and you can see it down here located, and it's 1861 S7. And this says that it has to be medically necessary because it uses the word contraindicated. That means the only safe means of transport. So before you consider even billing the hospital for it, could this patient have gone by a different means of transport to whatever the end result is? If you answer yes, then that will not be a bundling situation or it won't go to the hospital. So we'll talk a little bit more about that. Billable by Part B. First, it's for outpatient services. Did you catch that? Billable to Part B is for outpatient services. Now, this is the individual ambulance supplier billing us. This means that we will pay the company for a payable medical transport. Billable to Part A. This means that the individual ambulance supplier must bill the hospital where they are inpatient at. So this is a Part A benefit, and that means that they're inpatient and it's payable to the hospital. Now the hospital says, wait, and one of the questions that we got in related to this is, as a hospital, I can never bill the revenue code for an ambulance, a 540 X revenue code. I understand that because it's part of a bigger picture. You don't just take them from your hospital to another hospital and back or to another location and back. You take them for a bigger picture. And so that's what we need. This ambulance transport becomes part of another item. That could be a test result, that could be an MRI, that could be a variety of other things. It's just not a separately payable. Now under Part B, it is separately payable. So if you're billing on a UB04 or 837I, yes, you could put the 540X revenue code. If you're billing on a 1500 or 837P, then yes, you would use those appropriate codes. So that's the start of it right here, is to make sure that one, you know when you can and cannot bill. Also when the hospital can and cannot bill. All right, let's move on from medical necessity. Bundling. Ambulance is not excluded from inpatient hospital bundling, and that's a very specific section, and it's called Part A hospital bundling. Now, the reason that they do that is just because a patient's in a hospital doesn't necessarily mean Medicare is still paying for that hospital stay. Remember, the hospital inpatient benefit is a defined benefit. That means that if it's a hospital, you have 90 initial days. Now, that's the first 90 days in which Medicare will apply deductible, will do all of that. But then there's also something called 60 lifetime reserve days. Those are days that a patient can elect. So it's a total of 150 days, but 60 will only occur once. 90 can occur many times throughout a patient's lifetime. Just depends on the break in between. So when we look at hospital bundling, we first need to make sure that they're in a Part A stay. So that's one of the key things. So this is why we're talking about this in packaged institutional services. This is the actual internet-only manual, the day-to-day operating instructions that you need. It's the Medicare Benefit Policy Manual. This is where you're going to find that. If you are not familiar with it and you do download this, if you simply click the link right here, what's going to happen is it will take you right out there. I just wanted to show you that the links are actually built in so that you're not doing extra work. So when we look at hospital bundling, you will bill the hospital for all covered services. This would include a medically necessary ambulance transport. The patient must be under an inpatient admission. You can bill for round trip coverage. Now, Medicare does not typically cover round trip unless they are inpatient in a Part A hospital stay. Then you can bill round trip. And round trip means to and from a facility. So they went to get an MRI and they came back to your facility because they were inpatient at that facility. That would be considered round trip and billable to the facility. The other part that I just described is they have to be in what's called a Part A stay. And this means that Medicare is paying for the room and board. So they're paying for those hospital, the nursing care, all that stuff that goes on in the hospital. What happens again is after a certain number of days, and that's 90 for a hospital, unless the patient elects that one special lifetime group, and that's another 60, so it could be up to 150. If Medicare is not paying for it, then we do know that that will be separately billable. So let's say they're in the hospital, but they're no longer in a medically necessary stay. They just haven't been discharged home yet. So they're in for a couple extra days for whatever reason. That would be when Medicare would say, nope, you bill that because it's not medically necessary at this point. Now, for those of you that don't understand that, that's a quality of care issue, and the patient says, I should not have been discharged. Here's what's going to happen for that. The patient can then be found liable for that. Long story short, it's not considered a Part A stay. So we really want to check with that. If you don't know, there are a few places in the systems that we can check, and we'll talk more about those in a little while because we did have some questions come in and I do want to address that, but I just wanted to let you know that we will get to that. Oops. The next slide is interfacility transports. Now this is one that came up frequently in our questions. So the first one is actually designed to answer the question, what is considered off campus and on campus? So Medicare says a hospital can actually own something, but not be directly correlated to them, not be right on the same physical location. Now, they don't say the same postal zip code. They don't say that. They also don't say the same postal street address. There's nothing to do with that. Instead, what they do is say it's 250 feet of each other. And in the example that was given by someone, and thanks for the example, I really do appreciate this. They have a hospital, and then they have some specialized care services that would be done as part of the hospital. Now they have two separate street addresses, but the reality is they're back to back. They face two different streets. The front of one faces a certain street and the front of the second one faces a different street. There's just an alley in between and there's a narrow bridge that goes over. So it's really, in their opinion, one building, and that would still be on campus. They're not 250 feet apart in terms of that narrow alley that's in between the two buildings. So when we look at that, we do say, why are you using an ambulance to transport them back and forth between those two buildings when it's on campus? We really do want to know, what's the medical need to use that? So the other portion is off campus. Now, off campus simply means something that is independently owned or is owned and operated by a hospital. It's not an independently owned item. So an off-campus emergency room or an off-campus ambulatory surgery center or an off-campus outpatient center, something like that would be off-campus. So how do we use that? By definition, it's 250 feet or more away. So that's off-campus, two separate things. When we do look at that, we still do look at medical necessity. We're still going to look at why you needed to move them that distance. However, there are some other criteria that would go into that. And so we've had questions on EMTALA, which is a separate law, but it says, hey, I can't send someone away from me. So how does that work? That's fine. We don't look at that in that manner. We look at locality as in, would they normally go there? So when you're talking about interfacility, if they're in the ER, this would be an outpatient hospital to an inpatient hospital status. They're treated at the ER, but we now need to admit them. It's still a hospital-to-hospital transport. It's just outpatient to inpatient. The transport would not bundle in that case, which is the question, because it's a outpatient hospital to an inpatient. On the other hand, there is one where they said the actual MRI facility, the diagnostic facility that this hospital has, is about a mile away. And so they feel like it's medically necessary to transport that patient to the MRI center and back. Again, still considered part of the same hospital. It's just that it's a mile away. And that is considered off campus. However, it would be billable because the patient was inpatient at the time. So hopefully I'm answering that in a way that you understood. And so it just really depends on it. The one question that came up also with this one is, Is there a different medical necessity requirement for on-campus versus off-campus? And the answer is no. You still have to tell us why they were medically transported. In other words, what did the EMT assessment prove or show that the transport needed to occur? There's no separate difference there. Same thing would go for an ER, off-campus, whatever the situation is. We still need to know why that EMT has to be the person involved. Question related to that was, when I say EMT, when Tom says EMT, I'm talking about an emergency medical technician. Now remember, CMS does define this as basic, intermediate, and paramedic. So when we say EMT, we're encompassing all. If I need an EMT basic, I will say an EMT B. If I need an EMT intermediate, I'll say I. And if I need an EMT paramedic, I'll either see paramedic or EMTP. So keep that in mind. Hopefully I answered all of those questions as well. Next one, mileage. So does Medicare consider mileage when we use different factors? Sure it does. How do we look at mileage? First of all, if it is an inpatient stay, we don't determine mileage. It is part of the procedure that's done. So you would bill your base rate and your mileage to the hospital. You would also bill supplies, any other thing you needed to bill to the hospital where they're inpatient at. If for some reason we are looking at mileage and it is not bundled, in other words, it is a Part B stay, so it's a hospital to hospital transport, but they're no longer Part A. In other words, Medicare's not paying for that stay anymore. Then what we'll do is we'll determine which facility falls into the point of pickup locality. Now what that means is we use a zip code and we use data to data mine and say, okay, these are the common ones within this locality, within this area. And then we also look at the nearest appropriate facilities. What is bed, staff, and equipment? Now, if your facility falls within the locality, we're fine. But if it doesn't, yet it's not normal for that person to go there, but it's also the only one that has the staff available, that has the equipment available to perform those tests, that's okay. So we do have to look at a variety of factors, and it's not standalone. It's not a certain number of mileage. There's a data-driven element that goes to it. And yes, there's a data-driven program that shows us and says, okay, this is what you're looking at. Here's what we do with that. The one thing that falls outside of that is, like, if there's a time constraint, so this staff is only available from 8 a.m. to 8 p.m. Otherwise, they're just, this or things like that. We don't necessarily know that, and that's where you may need to document that when you talk about mileage considerations. Also, though you're doing a hospital-to-hospital transport, if you're doing a two-way transport and it's under Part B, now remember, this is not when they're inpatient in a Part A stay, they're under the Part B criteria, which means Medicare is not paying for the inpatient, so it's two separate transports. We need to know why the second transport back is medically necessary. Why couldn't the facility that you took them to have that test, to have whatever needed to be done, treat them? Why couldn't they do whatever needed to be done? Why couldn't they keep them? Now, there's very simple answers. Hey, they don't have a bed. Yeah, great. I can do the test for you. I can do the MRI for you. I can do the cath lab portion, but I can't keep them because I don't have a bed. Two different things in that case, right? But we still need to know that. And that's for a Part B stay. Oh, by the way, if I do say Part B stay, when I'm talking about Part A stay, that's inpatient Medicare Part A is paying. When I say Part B stay, keep in mind a Part B stay simply means Medicare Part A is no longer paying, but they're still inpatient for whatever reason. So we want to make sure we're getting that one as best we can. Let's talk a little bit about some documentation things. What needs to be included? What's going to happen is, even if this charge gets built in, the hospital will need certain pieces of documentation. Because it's still a component and it's billing a certain amount, they may need to be able to support why that amount was done. So we need to make sure that this is being done correctly. So ambulance supplier information first. Who are you? That's your basic stuff, right? Then the patient information. Yes, this belongs to this patient. Here's their name. Here's their date of birth, all of that. Signatures. Was it an authorized service? Could it have been done correctly? So we want to make sure. Transportation date, time, the assessment. I want you to highlight, circle, draw a big asterisk, whatever you want to do. This is key. What are we looking for with an assessment? When an EMT at any level, remember this is basic, intermediate, or paramedic, has to assess the patient to say, yes, it's medically necessary. If they don't, then Medicare doesn't the Medicare doesn't say yes, the service is medically necessary. It doesn't happen that way in a transport like this. So you want to make sure that the assessment is done and it's documented. That then also needs to go with it when you send the bill if the facility requires documentation. That's part of what we're using to prove the service was medically necessary. We always want a transport reason. I always tell everybody best to get 2 reasons. One, why were you dispatched as an ambulance supplier to this? And the hospital, why are you dispatching them? But also, what happened when you got there? And is it the same? Is it different? The reason that I say that is how many times have you experienced showing up at a location and they're like, we need a transport for this. And this is what they said to dispatch. You get there and you're like, what? But that's not the situation. This person is doing this, or this is this other situation. So we like to have both of them if they're different. If they're the same, great. We have transport reason. Action logs, these are your run sheets, your run reports, your action logs, your action sheets, your action reports, whatever you want to call them. It's what happened during the trip. So we want to make sure that we're doing that. Inpatient transports do not require physician certification statements. I want you to circle where it says inpatient transports here. This is talking about a Part A transport. So a Part B may require it, right? You may have a scheduled, you may have a medically necessary transport, you may have a one-time transport. You may not be able to get that from the physician, so you may have to do some other things to document it. So when you say it requires a physician certification statement for a Part A, we're not going to look at that. That's a hospital to hospital Part A, say. Hospital to hospital Part B state, we would look at, one, do you have a physician certification statement? And if you don't, what attempts did you do to get it before you billed us? Did you get it from someone else, such as a nurse or an RN? All of those types of information. So you want to follow the other criteria. But a key thing there is the inpatient transports. The Part A ones do not. And the reason that I emphasize that so much is we actually had 3 questions on it, so I wanted to make sure I addressed it. What are you going to ask? How are you going to try to determine this? And the answer is you really need to ask some questions to help you do this. 1, what is the patient's inpatient status? Are they in a Part A stay or a Part B stay? Now, some people may not know this, and I will show you a couple tools you can use later on. I'll answer those questions a little bit later. Is the patient in observation? This is key. Remember, observation is always a Part B stay. It means they were not admitted into the inpatient hospital. They're under observation care. Therefore, it's Part B. Therefore, you follow the Part B Medicare rules, which means you bill Medicare directly. Did you pick the patient up in the ER or emergency room? If you did, odds are you're going to be in a Part B stay. Now, you do need to ask, hey, were they admitted, whatever. This is the ER is key here for this one, the emergency room. Is Medicare paying the inpatient care during this benefit period? So they're not in an observation stay. You didn't pick them up, but did you pick them up from a hospital bed or a department? And oh wait, Medicare is paying it. Now you've got Part A stay. If you said no, Medicare is not paying it, which again would either be at 90 or 150, it just depends. Then you've got a Part B stay, and then you would build Medicare Part B directly. So hopefully all of that kind of tells you what you need to ask and what you need to look for. Now, again, some of the systems will be able to show you that. What that does at this point is brings us to our first sets of questions. So first one we have, I'm going to go ahead and go through the pre-submitted or the ones that actually apply. Then I'm going to have Leanne ask us any questions we have in the chat. So bear with me. So first question that was submitted during registration, how do you determine from the patient eligibility to bill the facility or Medicare? So first, you have to determine whether the patient's in a Medicare Part A or Part B coverage. Then if they have Part C coverage. Now remember, if you use our system, which could be DDE if you're a UB04 or 837I biller, it could be the portal, which is that secure section of our website, or it could be the interactive voice response. These are all part of the eligibility features for that. You can actually look and see what the latest Part A stay is, whether it's still ongoing or not. Now, this does have one limitation. If the hospital hasn't billed it yet, it won't be available. So while this is great to go into the eligibility feature and go, oh, look, it's right here, it's under this, it's not really going to help you. Which does mean what information is available is the next question. So what system information or what systems and what information is available to help determine if this applies? Now we're talking again, systems. The claim must be billed, and we already talked about that. The portal, which is where we recommend going, will give you the most data. And the portal does show your lifetime reserve days left, your copay days, your psychiatric hospital days, your hospital days, and your copayment days. Now, please understand that when you say psychiatric days, that still a hospital stay. It's just a little bit of a different benefit. So they still enroll as a hospital and it still falls under this hospital to hospital transport. So can an actual acute care hospital own a psychiatric facility off campus? Absolutely. So then you go to the Part A deductible. You have your benefit days. This will give you your benefit, your lifetime reserve days, and your copayment days. Again, it's going to tell you how many days are remaining, whether they've been met. So there's a variety of different items that you can get, and all you're going to do is look at the portal and go into that eligibility feature. I think it's a great opportunity for you guys. Before we go on, Leanne, do we have any questions?
Yes, we have several, Tom. The first one is two parts, so I'm going to give it to you in two chunks. The first part is, I'm still not clear on these scenarios. If the patient goes from an off-campus emergency department to the main campus as an inpatient, is the ambulance fee paid to the ambulance company or to the hospital?
Okay, so for that one, the patient status is what's going to drive this. Now, most of the time when they leave the off-campus emergency department, they will still be on an outpatient basis because they are not at the hospital and admitted as an inpatient. Why do we say most of the time? If for some reason the main hospital was full and they chose to keep them inpatient in the ED ward for a period of time, they could actually be admitted there. So if they are outpatient, meaning not admitted into inpatient, this will be probably most of your transports, then you bill Medicare Part B, not the hospital. If, on the other hand, you have that weird anomaly where they held them in off campus, but they did admit them, then you would bill the hospital. So hopefully that does answer that question. If not, throw that back in. Let's get you some more clarification. Leanne, what's the next one?
And the next one I think you're touching on a little bit, but I'll read it anyway. If the patient is transported from the off-campus ED owned by the hospital to the main campus as an outpatient observation patient, is the ambulance fee paid to the hospital or ambulance company?
In both of those situations, the patient is considered outpatient. Again, emergency department or emergency room is still outpatient. So is observation. So they can transfer them. We're not saying don't transfer them. We're not saying don't do that. What we're saying is that Part B, that Part B benefit will cover both of them. Therefore, the transport is billable to Part B as well and should not be billed to the hospital because it's two Part B benefits. Actually, all three are Part B benefits. So do we have any more?
We do have a couple more. So the next question is, how do you communicate to Medicare that it is the nearest appropriate facility when mileage is excessive?
Ooh, good question. Really, the easiest way to do that is to document why that was the nearest appropriate facility today. And this can be done at the dispatcher. The dispatcher says go here, or the hospital said go there. Let me give you an example of one that came to my mind recently. There was an auto accident. It was an autopilot. It was a 12-car accident on an interstate. Because of the number of patients or the number of people involved in the accident, it actually was taken to two different facilities. One would have been considered the nearest appropriate facility, and the other one would not. It was actually an excessive mileage. However, along with that, there were some other issues where the ER at two other facilities was full. They literally said, you got to bypass us. We can't take patients. Making this third one, which was further away and actually beyond what we would consider the nearest appropriate facility or even within the locality, the closest one at that time. If you documented, hey, we contacted them and they said, hey, yep, nope, we can only take 10. And then you said, oh, no, we can only take, oh, wait, this one can't take any, this one can't take any. That's what you're looking for. Now, again, you could do something even down to the weather. We didn't go to this facility because there's a weather front and it would have been unsafe for us to transport through that weather front. That will document excessive mileage or why you went around or why you went additional mileage, however you want to say that. So please make sure that you're documenting whatever it is and you want to document in the narrative. Doesn't necessarily need to be the EMT documenting. It needs to be somewhere so that we understand why, because sometimes that decision is made even before the EMT sees the patient. Hopefully that all makes sense. Just needs to be documented. Tell us why and who made the decision, why it was made, whatever the situation is. So I'm going to go ahead and stop with that one there, and then we'll move on to the next one. Again, if you have more on that, throw that back in chat.
Tom, we have two more questions. The first one is, should all medications be in the documentation in the billing narrative?
We would recommend all medications. Let me clarify. If you're giving a medication, yes. So if you're doing an IV push or you're not doing an IV push and you just gave him aspirin or something, like that, yeah, you still want to document that. Now, if you know a patient's medication and you know that for whatever reason they're on it, you may want to document it in the narrative. You may want to document they have it, even if you're like, it doesn't really affect anything today. that's okay, but Medicare says it's better to have it documented in that manner if it's known. So always put what you know in there as much as you can. Next question, please.
Last question we have in the chat at the moment is when a patient is transferred from an inpatient stay to an office for a procedure 2 miles away, for example, what place of service do we bill for the office visit?
The office visit, so keep in mind the ambulance is still going to be part of the, you say inpatient stay, I got to be very clear here. If it's an inpatient stay and it's part A, that all gets billed back to the hospital. Okay, because I'm not really sure what the procedure is, but it should all be billed back to the hospital. Doesn't mean the professional component will be. That documented place of service will be what would be a inpatient hospital, because that's where they're at the time. That's what the Medicare billing system requires. I know they're not physically there, but that's what Medicare billing system says they're at. Now, if it is an out Part B stay, then we want to look at, okay, is it even going to be covered? Because is that a physician's office? If that is, Medicare doesn't cover those types of ambulance transports. Does that physician's office qualify as something else? Then we would not be using the physician's office code. We would be using a different type of code. So that one gets a little bit trickier when it's a Part B stay. So they could go there. They want to make sure that it's getting coded correctly. And the transport itself would, the office itself, if it's a Part B stay, would still be the place of service office. Any other questions?
That is it at this time.
All right. That brings us to the billing section. Now, some of this stuff has already talked a little bit about billing, and some of this would have kind of fit into that category, but hopefully this will help you a little bit more too. In answering some of those questions, you've heard me quite often say bill Medicare directly. So this is when you want to bill Medicare directly to the hospital. In other words, where are they coming from on an outpatient basis? You want to bill that directly. So they're not coming from anywhere related to a hospital stay, even a skilled nursing facility. We want to make sure that gets billed correctly. An emergency room, well, I already talked about that. An emergency room is considered outpatient, therefore to the hospital is considered outpatient. You're going to bill Medicare for that transport directly. Observation care. This was one of the scenarios we already got to, but observation care is absolutely outpatient to outpatient, therefore Part B gets billed. After discharge, and if the benefit stay is expired. Now, this is when we talked about the Part A and the Part B stay. These automatically will be billed to Part B. This is when you have to determine and make sure it's done right. Okay. Remember that when we look at this, Medicare considers these separate trips if you're billing Medicare directly. We still have to follow the separate trip rule. So we still have to look at one, why was it medically necessary? Which means what does the EMT's assessment show? Two, what else do we do when we look at this back and forth? Why is the back? Not the two, like we left here and we went there, great, that one's good. When we went back to that facility, why was it medically necessary? Why couldn't they have stayed where they were at? Because that would be, for Medicare, a more logical choice. Now, again, there are a lot of circumstances in which that doesn't happen. We just want to know why that is within that information. So just so you're aware. So if they, observation care, this is where we see this one quite frequently, just so you know. I'm in observation care, I need an MRI. Today our MRI machine is all scheduled out. I cannot fit you in, but if I send you 10 miles away, we got another MRI machine, we'll do it over there, we'll bring you back because that facility doesn't have any inpatient beds. They can't keep you. That's where we're looking at here. Now, that's a Part B stay because you're already outside the 100 days, even though you needed the MRI, that doesn't matter. You're already outside the 100 inpatient days. So lots of things going on there. We want to make sure you're aware of those. All right, so let's talk a little bit about hospital billing. When the hospital goes to bill, they must bill this as part of their procedure or service at the destination. And I think I said this before, but I want to make this as clear as possible. This means that if you're doing an MRI and the hospital is going to bill for that MRI, the ambulance charge goes onto that revenue code and that procedure code. It does not go onto a separate line item for that data service. It's not going to pay that way. It's actually going to cause a lot of problems. Don't do it. So you want to actually look at the total end result, incorporate that into that end result, and that's what you're going to pay for. So the hospital billing becomes a little confusing and some people don't like that. However, we were asked a very specific question, and I do want to address this with this next slide. Does the hospital bill the same as an ambulance company? Now, this one was a little bit hard for me to interpret, so I put together this slide, hopefully to answer it, and hopefully I don't miss anything. If I do, please put that back in the chat. But when you look at claims, hospitals bill claims on a monthly basis. They bill the first month, which is your admission month. Then they bill an interim, and then they bill a discharge. So there's a lot of other things that happen. Now the discharge would include if they stay in, but it's no longer Part A. Okay? So they're billing monthly. Then you hit, can they bill late charges? And they can. The problem is when you look at how they have to bill, everything has to come in and sequentially process. Your admission has to come in first, that has to process. Your interim has to come in, that has to process. And then your discharge comes in. If at any given point something breaks in the middle, they will not get paid for the remaining. So that could include something like adding additional charges or adjusting the claim to fit your ambulance service onto it. That can stop it. So yes, they can bill late charges, and yes, they can correct claims. The importance of it is that if they don't have all of the information right away, it can affect later billings, which can actually affect their revenue as well. And so we wanted to make everyone just aware of that, and so that I think I'm answering, does the hospital bill the same as an ambulance company? I'm not really sure. I hope I got that answered correctly with this slide. If not, again, put that back in chat for me. Next slide is payment. So we had a lot of questions come in about getting help with payment and understanding payment and what happens if the hospital refuses or doesn't do those correct things. So let's just talk really about that. First of all, Medicare cannot be involved in, or WPS, GHA, we cannot be involved in a dispute on whether or not the ambulance needs to get payment from the hospital. What we can do is say, no, we show right now that they are in the hospital, they're in a hospital state. Maybe they've been discharged and it just hasn't been billed yet. That is also not uncommon. Remember, hospitals bill differently, so sometimes we just have to wait for that discharge to come in before yours go through. If the facility does owe you money, the recommendation from us, CMS will give you the same information. You're going to put them through the same collections process as anyone else that owes you money. If you automatically write it off, then that means you should automatically write all those services off. If you do 4 pursuits and it's costing you too much money, so therefore, then that's what you're going to do. So hopefully all of that makes sense. Now the facility will then pay you out of their payment. The reason that some facilities are affected differently is their payment methodologies are different. Some are diagnosis driven, some are actual cost driven. So there's a variety of different payment factors that go into that. On the Part B side, we will pay you under the ambulance fee schedule. A facility is not obligated to pay you underneath that fee schedule. There's no obligation to do that. They can pay you whatever they want up to the amount that they want, but they do have to pay you something. Now, if you say, no, we absolutely will not accept less than we've billed because we don't have a contract with you, we don't have an obligation with you, that's also something that you would need to go through that collections and that legal process for. It's not something Medicare can be involved in. Remember, when you're looking at the Part B where Medicare is paying you, I have to have the correct point of pickup zip code. If not, your payment will be incorrect. This is based in a question that we got, but remember the point of pickup zip code drives that payment differential factor. Some people call it the urban, rural, super urban areas, all of those different types of differentials that you get additional money for. Wrong zip code, wrong payment factor. And yes, as a matter of fact, you can have hospital to hospital transport, in which case a rural adjustment applies. Sometimes we have freestanding ERs or critical access hospitals. It just really depends on a variety of factors for rural. It's not meant to be a standalone item. All right. Brings us to our next set of questions. Here's what I want to do again. I'm going to have Leanne gather questions. I'm going to go through some questions that were submitted registration, and then we'll come back to it. How long does an inpatient stay take to register in the Medicare portal? Don't have an answer for you that's really accurate. It can't be 10 days or 30 days or 60 days or 90 days. What the answer is, the portal will show after the claim is processed. So not only does the claim have to come into our system, the claim has to complete processing. So let's give you an example. A hospital says, oh, they were only inpatient for 15 days. So the 1st through the 15th of the month. That is a discharge claim. Admit to discharge claim is going to be one claim. They choose to bill that at the beginning of the next month because that's how they do their billing cycle. So that would come in on the 1st of the next month. We then have 14 days or 30 days, depending on if it was billed on paper or if it was billed electronically, to get that processed. So you can automatically see, okay, this one's automatically going to be so long after, right? About 45 days if it's a paper claim, about 30 days if it's only electronic claim. But what does that not take into account? developments, other things that happen. So until that claim fully processes, and by processes we mean it has to allow. If it denies, it won't show up in the system because it's not a valid claim there. So it's a really hard question to answer because there's so many factors that go into it. The next question was, determining who to bill for inpatient seen in a freestanding ED. We have an order written for an inpatient admission to acute care hospital. And who do they bill for this? Keep in mind, again, that emergency room department is an outpatient department. So unless for some reason they were admitted during that emergency room and held there for a period of time, which would be then make it an inpatient stay, you would bill Medicare directly because they are going to an acute care hospital for the admission, and they're not allowed to be an inpatient until the admission occurs, which would be at the facility. So we want to make sure we're well aware of that. With that said, I'd like to ask Leanne if we have any questions.
We have one question, and it's going back to your slide 13 about billing. It's asking you to please clarify who bills Medicare directly, the ambulance company or the hospital?
So assuming this is the slide that we're at.
I think so.
So when we talk about this one and we're talking about bill Medicare directly, this is ambulance suppliers billing Medicare directly. So to the hospital, not from another hospital where they're, or could be from another hospital, but where they're not inpatient, whether it's Part B paying, or whatever, so there's no more inpatient days, or whether they're simply not inpatient. So you're coming for an emergency room, you're coming for an observation care, whatever the situation is, they're not inpatient. And so I believe this is what you're talking about, but this one gets billed by the ambulance company. That's why it's labeled ambulance. Unlike the next slide, which should have been labeled hospital. Okay, so this means they're in a Part A stay already, and so this one is billed by the hospital. Hopefully that clarifies it. If not, let me know back in the chat. And Leanne, do we have any other questions?
We do not at this time.
Okay, I'm going to scroll back down, you guys. I'm sorry, I jumped back up just to see what slide I was talking about there. Let's talk a little bit about some of the actions that may occur. Now, there's a variety of different actions that occur, and we know this. So some of the actions are going to be simple, other ones are going to be harder. The first action that occurs, and that a lot of people ask us about, is determining whether or not the information's in the portal. And how do you determine? That's our end, right? You got to determine whether or not they're inpatient, whether or not it should be billed to Part A, whether or not through the hospital, or whether or not the ambulance company should bill Part B. So to do that, we do want to give you the point that you're going to come in and again, you're going to do the eligibility check within the portal. So on the summary tab, and you can see I didn't go anywhere, it's right here, it's highlighted. This means you entered your eligibility search and you brought in the summary information. It's got a few days right here in the middle, and you can see these are your psychiatric, your co-payment days, all these different things that you want to make sure of. Apparently my circle shrunk because it should have been around the Part A data, the whole thing, not just a portion of it. And I apologize for that, but that's what you're really looking for. Hospital days, these are your 90 days, lifetime reserve days. These are your additional 60. Psychiatric days are part of that, but psychiatric benefit hospital or psychiatric care by diagnosis is only for a limited number of days as well. So I think that's what you're looking for. I hope that's what they were looking for in regards to this. If not, let me know again in the chat and I'll get you a little bit more information on that. The next action is what is if I get an overpayment, but I don't agree with it. In other words, Medicare is saying, hey, you owe us this money because we show they're inpatient. First, when we request money back, remember, this is an automatic trigger in a lot of cases. And here's how that works. Your claim got processed. The reason that it got processed is because you sent it in before the inpatient bill arrived or the inpatient bill completed processing. So then it places it out through the common working file. Common working file, it's like your central data storage hub. It's just a big informational data thing, but it tells us, hey, is there a Part A claim? Is there a Part B claim? Do they overlap by data service? What are we looking for? Is one inpatient? Are we still paying that inpatient benefit? It's got all kinds of information in it. Now, this would include basic eligibility information, it would include Part C information, would include the Medicare secondary payer information. So you can imagine it just keeps getting bigger and bigger and compounding upon each other. So when an inpatient claim comes in, it's going to check and say, okay, they're inpatient in a hospital. If Part A is covering that, then it's going to say anything that was covered under Part B that shouldn't have been, it will automatically send a letter out. It triggers us to manually build an account and say, hey, you owe us money. Here's your letter for it. Did you catch that? It triggers us to do all of that. So we don't really get a choice in it. It's going to happen. Now, the part that triggers, that is an automated process. The actual manual process comes in making sure that everything is done and making sure we get to that. We don't get an option in it. It actually will send the letter out, and we just got to make sure the account is receivable is correct, all of that type of thing. If you disagree with your overpayment, you do have the right to request an appeal on the overpayment. What you need to do is show that this patient was not inpatient at that time of service, that data service, or that they were inpatient. However, Medicare Part A is not paying for it, whether it's because it wasn't medically necessary or because the Part A benefit's just done, and that final claim may not have come to Medicare yet. So when I always talk about overpayments, I like to tell everybody, make sure all of the Part A stuff is done, because it becomes very key to make sure those pieces of information are done as well. If any of that isn't done, sometimes we can't close the overpayment until that's done. All right, so we want to make sure we're doing that. Keep in mind, manual medical review does require a variety of different things to happen. We can look at it from the appeals process, and that's what we're talking about in this case, but it's not all that happens. We have gotten a lot of overpayments related to actual medical review, not related to the overpayment process. So the medical review caused the overpayment. How does this happen? There are a variety of contractors that are looking at these claims. Some of them are prepay and some of them are postpay. So for instance, when you look at WPS, the second bullet, targeted probe and educate, this is a prepay audit. You would never have a situation where an overpayment would come. Instead, we would ask you for medical records, and you do need to support that they were not inpatient at the time, that they were not any of those things. Now, if you say, hey, I don't have any of that information because whatever, also your origin and destination modifier will be able to do that, right? I went from hospital to hospital, except it was emergency department. Okay, that makes sense. We're still doing hospital to hospital, except it came from the emergency department. So hopefully all of that kind of helps you understand. On the other hand, there are post-pay contractors. The first one is the recovery audit contractor, and they have a very specific audit right now going on. It's a national audit, and it's for ambulance bill during an inpatient stay, and they're looking for unbundling. In other words, it was paid incorrectly, and we need to make sure it's paid correctly. This is not on WPS. It has nothing to do with WPS. However, if they have a finding and you disagree with it, that's when you would do the appeal to WPS. Also, the comprehensive error rate testing contractor for the improper payment rate will look at these as well. Their job is to review a sampling of claims. So you may or may not ever see one from them. Some people say, oh, I get it all the time. I get these. Other people are like, what? I've never heard of this contractor. Really, their job is to look at it and say, hey, here's a report. CMS, here's a report. Department of Health and Human Services, Congress, here's the report to say whether Medicare is paying correctly. That's what they're doing. So it's not about targeting ambulance in particular. It's about targeting claims and how we process them. And it could be any claim that got processed by Medicare. The last one, I hope you never, ever are involved with, but let me just mention that. The Unified Program Integrity Contractor is a fraud and abuse contractor. If you happen to get into a situation, they will request documentation. If you do not respond back and you do not give them all of the documentation, which could be the inpatient record, could be the outpatient record, could be the ambulance record, you want to give them whatever you can to get to support that, you can wind up in a fraud and abuse investigation, and they can take it up to a variety of different steps. But I wanted to make sure you've at least heard that name. Hopefully you'll never ever hear from them. Talk about what happens. Can you do an appeal? Yes. Any overpayment that's assessed to you, you can absolutely do an appeal. The key thing to remember is you have to appeal the overpayment. One of the questions that was asked is, I keep getting my appeals denied saying they're outside the timely file it, but my overpayment was just done 30 days ago. Well, that's because you may be writing in the narrative that it is a claim appeal and you're trying to appeal something related to the claim decision. That's not what you're appealing. The claim decision stands as it was. What you're actually appealing is that you owe us money for the overpayment, because the overpayment was done for this reason. That's what you're appealing, not the claim decision. So make sure you're very good at including that information. So make sure the transport's payable, include the time of the transport. If you do happen to have more than one on the same day, include an admission report. This is system-driven stuff. Sometimes the Part A system and the Part B system don't play nice together. So we'll deny something and we'll say, oh, no, they were inpatient at the time. And you're like, yeah, but they weren't inpatient until 1 o'clock and our transporter was at 10 o'clock to get them to that facility. Our system doesn't have those times built in. So sometimes that's what we're looking for. If you need more information on appeals, feel free to ask and read those questions. I do want to give you a couple of appeals tips coming from our Group Level 1 Appeals Department. One, always the documentation requested. This means it doesn't matter if you're doing an appeal or you're doing a prepayment or post-payment medical review. Make sure you send that documentation when it's requested. Don't send it on appeal. A lot of times we could have overturned that right away, or we could not have even had the issue if you would have just sent it right away. Two, for some reason, ambulance suppliers have started appending the modifier GY onto their claim, saying it's not medically necessary, then doing an appeal to Medicare to say, hey, it is medically necessary. If you append a modifier GY, you're telling us it's not medically necessary service, so you should submit a corrected claim without the GY. That tells us it's medically necessary. We will assume medical necessity unless otherwise shown, which would be through the review process. Always include the run sheet with the time. This is very important. And what we're looking for is the time of transport versus the time of admission. We want to make sure they're two separate times. If they're leaving an ER and you know something, include the information. If you don't know it, then it doesn't matter. Give you an example. We got a transport from an ER to a hospital for inpatient care. They sent us the supporting documentation for the test that the hospital ran, not the ER, the hospital. Well, that wasn't known. How could the ambulance supplier have acted on that? So we just want to make sure that you're aware. We need to be aware of it too. Here's a couple of tips and a couple of things to verify. One, verify the hospital billed their claim. Before you bill Medicare, before you're having all these things, hey, did you bill your claim? Especially a discharge claim, that final claim, that can cause some different admissions. Verify if the transport is to admission or after discharge. With that, that's when you may need to file the appeal, but what we're looking for is those times. Verify the stay is still covered under Medicare Part A. And if it's not, has the hospital billed to say, hey, this coverage has ended and there's no more days. Also, just verify you're billing the correct entity. So follow the instructions for that entity. If you need to bill a hospital and they need certain things from you, you do have to follow their billing instructions to get them that information. All right, let's hit up some more questions. I will go ahead and just read off some questions that we haven't already gone through. So stretcher transports to mental health facilities. This was the full question that I got. It said question mark. I'm not really sure what you're looking for, but what do you need? One, if you're leaving an ER going to a mental health facility, yes, that's a Part B service, so you still need to prove medical necessity. Why was the EMT needed? Why was the monitoring needed? What was the unsafe part at that moment for patient harm to themselves or others? Were they on medication? If they were medicated, that's what keeping them calm. What was going on that when the EMT arrived, they felt they were needed, okay? What is our expected reimbursement and should it be the fee schedule amount? I talked about this and no, it's not necessarily the fee schedule amount. Why do Medicare Advantage plans always deny for inpatient stuff? I don't know. I don't work for Medicare Advantage and unfortunately I can't answer those questions. Each individual plan has certain criteria they have to meet and we can't really talk about it. We don't know them. So you have to ask each individual plan. What is needed to prove the patient was not an inpatient at the time of transport? I've said this a few different times and it's going to depend on if it's admission or discharge, but you need the admission report to show the time and date or the discharge report to show the time and date. That's what's needed. Does this apply to hospital swing beds at a critical access hospital? And yes, it does. Hospital swing beds are not part of a different criteria for this one. Is there a non-emergency hospital to hospital transport? You bet there is. So if they're leaving an ER and it's not emergency, they are stable, but they still need to go to a hospital for inpatient care. Perhaps they are having something and then they know they're going to have a surgery or they're having an appendectomy or they're having, something like that. It can be a non-emergent hospital to hospital transport. That is acceptable. But remember, those rules then have to follow. Also, what if it's a hospital to hospital transport because of like an MRI? I'll give you an example. They're going for an MRI. They know they're going for the MRI. That facility can't keep them. So now we're going to transport them back. Those are both hospital to hospital transports. So we do know that this can happen. How do we bill for an inpatient psychiatric hospital? It cannot be determined if the patient was discharged for the ambulance transport. Check the statuses that I showed you in the portal. If you can't, you can bill Medicare. If Medicare then takes the money back, you'll have to go back to them. But what you're trying to do is just show that you did your due diligence to verify. All right. Do Part A bundling rules apply for 911 calls? And the answer is yes. The Part A bundling rules do not change for 911 emergency calls. I'm not sure why a 911 call would come in and they would already be at a hospital, but if it did happen, that would be the case that we're looking at. All right, I do want to give one more opportunity, maybe if we have a question or two. Anything?
Tom, we do not have any questions in the chat.
All right, well, let's go on then, which brings us to the end. I want to thank everybody for attending today. I really would encourage you to take that survey. Give me the good, the bad, the ugly. Help me understand what you like, didn't like. Any of that type of information is great. On that survey, also remember to include topics you want to hear about, you want us to cover. Please don't just put ambulance transports or ambulance education. We have done a lot of that. There is a lot of YouTube videos out there. There's a lot of Encore. I need to know more specific, otherwise I can't tailor it to meet your needs. So we do struggle a little bit when we just have those general comments. Always remember to review our live events page. We do offer more and more ambulance stuff, and we do intend to continue that. Don't forget to review those encores. They become very key to making sure that you're meeting all of your education needs. On behalf of myself, Tom Ryan, Leanne Foster, and all of Provider Outreach Education, I want to thank you for attending and participating today. We do look forward to hearing from you on those surveys and any comments that you have. We hope to see you again in the future.